Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hello, and welcome back to Unraveled, Understanding Complex and Chronic Disease. I forget the title of our podcast. We're unraveled, both literally and figuratively. My name is Eileen Ruhoy. I'm a neurologist, and I'm with my favorite person in the world.
Kaufman, welcome back.
Welcome back. Today, we are going to have a conversation about mitochondria. Those little pesky, buggy organelles that are in every cell of our body.
Right.
What do you know about mitochondria?
Well, I always like to start with the fact that it is one of the most miraculous events in evolution, all right? That an infection, and I want to remind everybody, it is an infection. These organisms, mitochondria, I don't know what their actual bacterial name was.
I think they're like known to be relics of Proteobacterium.
Yeah, billions of years ago, infected cells, karyocytes, right? And that became the symbiotic relationship of all time.
Right. I mean, so sort of the way that legend goes,
right?
They infected anaerobic nucleated cells and endowed them with oxidative metabolism.
Yeah, it's unbelievable.
Yeah, no, it is unbelievable.
And I love to emphasize the word infection because we're all trained, both physicians, doctors, healthcare people, and patients, to think infection bad. And that is just not true.
Not true.
There's many positive aspects of infection, and this is the most momentous.
And I think what's sort of sad is when you read some of the mitochondrial literature, there's a fabulous journal that I love. It's called Mitochondrial, and it has so much information about mitochondria and obviously much more recent research on learning about mitochondria. You know, mitochondria wasn't associated with disease until the 60s. So this is a fairly new kind of area of specialty. But I forget where I was going with that. Is that over the years, though, what we've learned is that they have, so let's take a step back. So mitochondria have their own circular genome. They have their own genome. It's 37 genes. It's double-stranded. It's a circle, and it's maternally inherited. And as we said, they were a bacterium, and so they just sort of functioned on their own. But then they infected our cells who were under anaerobic metabolism. They allowed these cells to now convert to oxidative metabolism, which allowed the cells to do a lot more stuff and have a lot more function. But over the years, somehow the synergy and the symbiosis between these bacterium and our own cells they've given up their autonomy. So they are now very reliant on the nuclear genome of our cells within the nucleus. And so they're not as autonomous as they were, way back when.
True, but without them or when they're sick,
for sure. They still are.
We are profoundly disabled.
Yeah, we are profoundly disabled. And technically mitochondrial disorders are disorders of energy metabolism is how we think of it. But it's true that we really rely on the nuclear genome in fact, so the mitochondrial genome have 37 genes, and there are 350 genes that have been implicated in mitochondrial disorders. So all the rest of those genes come from the nucleus. Yeah. So it's important to sort of note that while, we always think about how you inherit your mitochondria from your mothers, which is technically true, but because there's a nuclear genome contribution to the integrity and the bioenergetics of the mitochondria, they can be X-linked, autosomal recessive, autosomal dominant.
Darn. So that means I can't blame my mother for everything?
You can't blame your mother, no.
Darn.
Not only that, but a couple of years ago, there was a paper that came out that showed that some people hold an enzyme where it inactivates the maternally inherited mitochondria, but you can somehow then activate the paternally inherited. And maybe that was proven not to be true. I don't remember. But I remember thinking, so the mothers can't be blamed for everything. Right. So
I think your point about this coming to the fore in the 60s, which may sound like a long time ago, but it's a blink of an eye in science, is really important. And if you then move that forward to now, I'm not sure everyone would agree with me, but I think mitochondrial science and immunology are the two most important things going on in medicine and science today, in human medicine,
For
biology.
sure. For sure. And we obviously everyone learns in school that it's the the energy powerhouse of the cell, which is true. It makes the ATP, which is the form of energy that all of our cells use for all of their functions. And depending upon how metabolically active an organ is, will dictate how many mitochondria are present per cell. And so what is metabolically active? The brain, the heart, the retina, the muscles, right? The GI tract. So there are thousands of mitochondria in these cells. And so, anything
Per cell.
per cell, exactly. And so, and that's an important point because mitochondrial disorders in general are usually multisystemic. And so we think about this with our patients. And in fact, in the chronic fatigue world, I know there's been in recent years for sure a lot of research on the role of the mitochondria because the post-exertional malaise and the chronic fatigue component of these patients and all fatiguing illnesses, frankly, you can't help but think about the mitochondria,
Right.
or at least maybe it's a secondary role, but I suspect it's a primary role.
Yeah, I think it's a primary role.
Yeah.
I mean, I often have this conversation with patients along the lines of, I can manage the low-hanging fruit, their POTS, their heart rate, their dysautonomia, their gut motility, their SIBO, their leaky gut, their mast cell activation. And we have a lot of tools to do that. Where I hit a wall, and we all hit a wall, not just me, is post-exertional malaise and the related fatigue, which is clearly the 800-pound gorilla in the room, which is the mitochondria.
I agree.
And it's a huge challenge.
Right. And what hasn't been done for these patients are muscle biopsy studies. And so, we do muscle biopsies for mitochondrial disorders, and it's usually for, in the hospital systems when it's clearly a mitochondrial dysfunction, when we find mutations, sometimes we look at the muscle tissue to look for, the quintessential red ragged fibers, and it's called that because it looks crimson under a gamoric trichrome stain. But there are certain, with the tissue, you can actually look at enzyme complexes, and there's other stains that will show other suggestions and findings that are consistent with mitochondrial dysfunction. And so I do think that we should be doing more muscle biopsy studies for chronic fatigue patients. I do muscle biopsies. It's actually fairly easy these days. It used to be open and you would have to be in a hospital system, but these days, I do punch muscle biopsies, and so it's easy.
Well, I think those things haven't happened because up until now, ME/CFS was not considered a disease or a syndrome worth researching.
That
It
is
wasn't
true.
getting the funding.
That is true.
If you were a scientist, a postdoc, if you were a PhD and then a postdoc and you go into a lab and you say, well, what should I study? If you were to tell your mentor, I think I'm going to study mitochondrial dysfunction and ME/CFS, you'd be laughed out of the room and say, well, there goes your career.
Right.
Literally. I mean, I've read that. I've heard people say that. What's changed is long COVID, which has now forced people to look at this problem because ME/CFS, as you and I keep saying, ME/CFS/long COVID, they're not different. They're more the same than they are different. Okay, and at the end of the day, it's mitochondrial pathology, and finally, hopefully, we will get to that level of true sort of bench science where they start doing biopsies and start doing metabolomics in there and start doing genetic studies and to get us somewhere. Because I think we meaning docs like you and me, we all know it's all about the mitochondria.
It is.
Hey, what is the Clinton thing? It's all about the economy, stupid. It's all about the mitochondria. And we know that. We don't know exactly why, although we have some ideas. And then the secondary challenge is, well, what do we do about that? So
right. So exactly. And so because I have done so much, I've done so much mitochondrial work in my past life as a neurologist, because I worked at a children's hospital. And in fact, I wrote a paper on Leigh syndrome, which is sort of the quintessential mitochondrial disorder. I wrote it with Russell Sinedo, who's like the mitochondrial expert at Seattle Children's. And it's been cited many times. I sort of have always applied that kind of knowledge to the patients in the chronic illness world and have gotten some success, but, we need to know more and we need to figure out more. And, it's important to recognize that, everyone talks about the energy powerhouse, of course, in the ATP. But, mitochondria have other roles.
Yeah,
And,
exactly.
they calcium homeostasis, which is important for, lots of different reasons, of course. Specifically, though, contraction of musculature.
Right.
And then apoptosis, right? It regulates
Well,
apoptosis and programs cell death. And then also it actually regulates reactive oxygen species, so free radicals. The oxidative phosphorylation process itself creates its own free radicals, but enough where the mitochondria have enough scavengers of their own
right.
to sort of control the level of free radicals. But once you are in the throes of a chronic illness, then there are too many reactive oxygen species, and it's too much for the mitochondria, and it actually can be very toxic and damaging to the mitochondria. So it's beyond the ATP. It's beyond the ATP molecule.
Point, Eileen. Crucial. The spectrum of what mitochondria do is awesome. Okay, in addition
incredible.
to what you said, it has a role in nutrient homeostasis, muscle and protein synthesis, autophagy related to the apoptosis issue, and maybe jumping ahead a little bit, many in the aging diseases of aging world are convinced and have the science to show that we get diseases of aging as we get older because we begin to have less autophagy, decreased proper nutrient sensing with mTOR, all of the things that lead to neurodegenerative disease, atherosclerotic heart disease,
Absolutely.
dementia, etc. And probably we'll touch on this a little later, but I have been talking to patients and to other docs. I think that's part of what we're seeing in our patients. It's as if it's this may scare patients, a premature preview of aging because of their chronic inflammation, which is why, we've really dived into what can we do to manipulate or impart greater health to the mitochondria, since that's the source.
Absolutely. So do you do a mitochondrial workup?
Well, what is a mitochondrial workup?
Well, so it's fairly extensive and sometimes can be hard to get, but I tend to prefer to sort of cover the genetics. And you can do, again, so the nuclear genome is important because the vast majority of genes that are implicated in mitochondrial disorders actually come from the nucleus. And there is an in vitro panel for the nuclear mitochondrial genes. And so I often order that. There is a way to order a mitochondrial genome sequencing so that you cover the rest of it. I will say that in the majority, though I've had some exceptions, the genetics don't show a particular mutation. And mutations are of different types. There are point mutations, deletions, but we're not going to get into the genetics of it per se. But usually the genetics are fairly normal. Sometimes there's a variant that's of significance that at least gives me insight into what might be going on. And then beyond that, as you know, so the mitochondrial, so the oxidative phosphorylation is also coupled with other kinds of metabolic processes, right? So things like the pyruvate dehydrogenase complex, the Krebs cycle, the carnitine cycle, the beta oxidation, the protein amino acid catabolism cycle. So you can test on LabCorp Quest some of the metabolites or the markers of each of those cycles to sort of see how well they're providing those substrates into the mitochondria electron transport chain, into the respiratory chain. So, and that is, so the workup that I do is serum amino acids, or urine organic acids, the acylcarnitine profile, because of the carnitine cycle that's involved, lactate, pyruvate, and ammonia. And so, and often because you can actually find elevated levels of lactic acid, actually, and then you just treat with sodium bicarbonate. It definitely seems to help when you find elevated levels of lactic acid. So I do that laboratory workup, and then I do the genetics, and I sort of that's how I start. And then if something comes back positive, then I will proceed with a muscle biopsy often. If everything is normal, but I still highly suspect mitochondrial dysfunction, then I might still do a muscle biopsy. It all depends on the patient and sort of their ability to actually tolerate a muscle biopsy. I mean, as you know, we have a lot of patients who are basically housebound,
Right.
if not bedbound. Many are not local. So, and it's very hard to order a muscle biopsy in hospitals these days. Back when, like I said, they used to be open. You would just, a general surgeon would do it. But now they're easy to do as an outpatient. They're not reimbursed all that well, which is a whole other topic again. So it's very hard to order them in the hospital systems. No one wants to really do them certainly for these indications. They'll do them in children because that's where a lot of mitochondrial disorders will present because they're very much associated with, developmental delays, seizures. So it's very hard on our patients, certainly, to order a muscle biopsy in a hospital system. So if a patient is able to come to me and tolerate it, then I will do it, and I'll send it off for some studies. And so, but I usually treat regardless because a lot of the treatment, by the way, is benign.
Okay,
like
so let me interrupt
it's harmless.
So, not to be negative and challenging.
I know. Are you going to say that I do too much of a workup?
Well, no, I'm not. I think doing these workups are great, but my question is, I guess, twofold. How often do you find actionable information, and does it ultimately alter your management? Meaning, I think we agree that regardless of what you find, unless it's truly a genetic disorder like Lee's syndrome or something, that it's mitochondrial pathology, and we need to figure out ways to try to address that, which I think you were about to say.
I was going to say that, yeah.
So I don't do the workup that you just described. I used to do some of it, and some of it I don't have the knowledge to do. If I do organic acids and amino acids, I'm not really sure what to do with that information. I have some idea. Lactate, I think, is very important, but I just assume they're all going to have elevated lactate based on studies that we did with the Stanford group and Ron Davis,
right.
Early on. So to me, the bigger question is, all right, great. $10,000 later, what do we do about this problem? How do we get substrates, food into that mitochondria? So you can take off on that. That's what you were about to get into.
Right. So I think the workup, so maybe I go overboard with the workup.
I'm not trying to be negative about it.
Sometimes I can't take off sort of that more classic conventional medicine hat. Like I want to sort of know what I'm treating specifically.
Right.
Like then I could put my hat on that, right? And say, okay, well, we have this problem but usually it's not a genetics issue. In fact, I think our patients seem to fall more into sort of a secondary mitochondrial dysfunction, which is just, it's like a burden on the mitochondria, right?
Yeah.
It's required to give too much to sort of keep this body going, which is why over time, I think, in my opinion, the septad thing or the dectad or whatever we're calling it now, because the organ systems start to falter, right?
It's like a domino effect.
Exactly, because all these disorders are multisystemic. I mean, just back to the genetics, if you have a point deletion, it's not necessarily systemic. It could be, a specific tissue or a specific individual and not necessarily, familial, but when there's just burden overall, then obviously it'll start with the nervous system because the brain and the cord are very metabolically active.
Right.
But you have to worry about the other organs. And then obviously the muscles are very much involved. And clearly our patients have difficult mobility. They report, the amount of muscle complaints that I hear, right? Not only spasms and weakness, but the fatigue and they walk to the bathroom and they could barely get back to bed kind of thing. This just screams mitochondria to me. And so I think it's more of a secondary burden overall. And even if I do find something in my workup, I still think there's a secondary burden. So it's just that they're more at risk of that secondary burden being a little bit more severe and maybe presenting a little bit earlier on kind of thing. Right. So again, back to the history.
A little like EDS. Okay?
Right.
So you can have a connective tissue disorder and be completely healthy your whole life and have a great life as a performer, an artist or whatever. But it does predispose you to greater problems should you get these other things in the septad that we talk about and you get ongoing connective tissue degradation.
Right.
So I think it's similar in the mitochondria. You may have a risk factor, but probably millions of people have those genetic risk factors or some version of genetics. It's the other stuff, the infection, the chronicity, et cetera, that starts to tip them over the edge, get the glass overflowing.
Right. Exactly. So I go for retreating. So, back when I worked in the mitochondrial clinic, with these kids who truly had mitochondrial disease, whether it was MELAS or MNGIE or MRF, myoclonic epilepsy with ragged red fibers, Lee syndrome, Kern-Sayer syndrome. I mean, there's a lot of very well-known, well-documented, somewhat understood mitochondrial disorders that affect the nervous system because, again, the nervous system is very vulnerable when there's a mitochondrial dysfunction or a mitochondrial disease. In this clinic, so first you do symptomatic treatment. So if there were seizures, you treat the seizures. Lots of and I do this with some of our patients, because they have seizure-like episodes, and some have clear seizures that are with positive EEG, abnormal EEGs. Some obviously have normal EEGs, but have seizure-like episodes that sort of to me, just represent sort of this hyper reactivity of their neuronal cells, and so and electrical abnormalities. So I treat them regardless with anti-epileptics when they can tolerate them. And so, they do symptomatic treatment. If there's musculospasms, you do, muscle relaxants, so you do use medications to treat any kind of symptom that comes out of mitochondrial dysfunction in general. And that's what we did. We treated, there are stroke-like episodes. Obviously, you try to minimize their vulnerability to having strokes. And so you would sort of do all of that just to sort of obviously keep them safe. And keep them as functional as possible. And then beyond that, we would do what we refer to as a mitochondrial cocktail. And I think that that's been thrown around now so many times over the years that I no longer know what people are referring to when they say cocktail. Back then we had a very specific cocktail that we gave. And I remember time after time, these families would come back and would say, oh, we ran out of these supplements for a couple of days. And clearly my child, there was a flare, got worse, regressed, whatever. So it was clear to me that we were providing these cocktail supplements, and it was actually had a therapeutic benefit for patients. And so, and they basically were antioxidants for the most part, and obviously substrates and cofactors. So the enzyme complexes, so the chain is, the enzyme complexes 1 through 4, and 5 is the ATP synthase, which is where it makes the ATP. And then there's 2 electron carriers. There's the cytochrome C, and then there's the CoQ10. And now there's a lot of research on CoQ10 deficiencies, and I think that we should be looking at that more and more. I've been ordering that more and more in my patients, and because you can order that at LabCorp and Quest. And so, but CoQ10 is clearly a mainstay of the cocktail, and if people aren't on it, they should be. Ubiquinol is the reduced form as opposed to ubiquinone. Overall, I don't think I think ubiquinone is more bioavailable though, so I always say, try to take a little bit of both. But I don't really think there's a great answer to that. There isn't research specifically into what is more effective. But it definitely is a cornerstone of it. And then there's, other antioxidants, things like vitamin E, vitamin C, L-carnitine, creatine, arginine. These are all, incredibly important. Riboflavin for sure, magnesium, definitely. So these are important antioxidants and substrates and cofactors for a lot of the enzyme complexes. I mean, complex 1 is multimeric, so it's important to sort of feed all of those different stages of its function. And so to feed these complexes will just allow them better support to make them work a little bit better. And that can, so I will have to say though, that some of the medications that we put some of our patients on, in classic mitochondrial training, you learn that, for example, antivirals can be mitotoxic. Yeah. You learn that there are some antibiotics that our patients are on that can be mitotoxic. Yeah. So, some of the aminoglycosides. So there are some medications that patients come on that I think, but they need to be on them, right? So it's sort of this, and it's like everything else we do with chronic illness, you have to sort of weigh pros and cons.
So let me continue my devil's advocacy role here. I do more or less what you do in terms of the cocktail. Usually I don't have to do much because the patient comes in with a page-long list of supplements they're already taking, maybe 23
they're
vitamins
usually on
and
these,
minerals and CoQ10 and everything you just said. My question for you is, do you think that's making a substantial difference in their PEM and fatigue? Because I can't honestly say that I see it.
So that's where I was going to go with this. Okay. And that's also why I started by saying that I was trying to make the distinction between when there's a genetic problem and when there's just an overburdened problem, right? I don't find that when it's a secondary problem to the mitochondria that this cocktail works as well. That's why I was bringing up the example of, maybe I'm not making sense with my rambling. No. But that's why I was talking about my experience in the mitochondrial clinic at a children's hospital, where the parents would say this made a difference because these kids truly had had mitochondrial
It's a very
disease.
different cohort of patients.
Very different cohort.
And I think that's
Right.
a reason, Rick Bowles, who's a geneticist and sees patients like you saw in the mitochondrial clinic,
Right.
he's put together these neuro needs, a spectrum,
Yes.
basically the cocktail in a single
That's
source.
correct. He has.
And I've used it, but no offense, Rick, I have not seen it make a big change. And I think it's because we are dealing with a different population of patients
That's right.
than children in the mitochondrial clinic, disorder clinic.
I completely agree, and that was sort of my point. And I obviously thank you for putting for putting
No,
the
I
pieces
think you're
of
making
my
it, but I want
rambling
to
together.
emphasize it because, we tried this mitochondrial cocktail, and I just haven't seen great results. Honestly,
Right.
the only thing I've seen, and I think we can talk about why in a second. The only one I've seen, and I don't want to get into sort of sounding like I'm plugging something, is the oxaloacetate, which is a step
Benadryl.
in that Krebs cycle to
Yes.
improve metabolism, and there's proof that it is low or deficient in ME/CFS patients.
Correct.
I have no idea why, okay? And then when I did that first pilot study with my own patients, I basically thought this was going to be a waste of time, but why not? They're giving it to us for free. We've tried everything else, nothing works. Let me try it. And it worked.
Yeah.
It worked. It was astonishing to me. And when I say worked, half to 2/3 of the patients had 25% or greater decrease in fatigue. And that may not sound like a big number, 25%, but when you're bedbound and now you can get up and go to the bathroom and make your breakfast, it's an enormous change. So we're doing the same trial now in randomized placebo-controlled, i.e. a real trial, seeing the same results to date. Why that single intervention is better than the 25 long list, I'm not sure, but it's reassuring.
It is reassuring, and I like their lozenges, by the way.
Yeah, right.
I take one of those a day.
Right. So it's on the one hand enormously frustrating. How do we fix those mitochondria? And I think there's other things we can discuss in a minute. I agree. I'll let you start it, but I have lots of other stuff too.
So it's sort of it depends how aggressive you want to be, I think, so I agree with you. So while I still can't help myself to sometimes recommend some of those supplements in the cocktail because it's so like part of what I know about the mitochondria, and if it gives them any relief, I'm willing to at least try it. It's certainly not going to be harmless, right?
And I think some are way more important. Like there's
Absolutely.
no question that ubiquinol is really important.
Okay? I agree.
Adequate high levels of B12 and folate via methyl replacement, very, very important.
Right.
Okay.
Right. Folic acid is a perfect example. Actually, it's been shown to be low and non-existent in Kearns-Sayre syndrome, which is again one of the quintessential mitochondrial disorders. So I do think that I borrow from that world, and I think about how certain things can have potentially a greater impact as opposed to all these supplements. Right. So I try to pick and choose things that have have research behind them in true mitochondrial diseases. So that's what I do. And then then there are obviously some medications that are thought to be mitoprotective, but sometimes they're contradictory to sort of other things that I'm trying to treat. So it becomes a little bit of a battle for me. And in general, I don't find, medications to be, I love rapamycin, frankly. I love rapamycin for it. Metformin there's been some research to show that it's not as mitoprotective as we had once thought.
So it's controversial.
Yeah.
I agree.
Yeah.
It impairs, it's toxic in quotes to electron transport 1. But the other half of that argument is that by impairing it, it activates other pathways to make the mitochondria healthier. So we're not sure.
We're not sure. Exactly. We're not sure.
Rapa we know a lot more about, and we should discuss that. Stem cells, of course, we'll talk about.
Right. So it is interesting that I think this should be talked about more often. There's a lot of I've given talks on this, which is why I'm just so passionate about stem cells in general, and I think that they really hold great promise for a lot of our patients. And I've given a talk several times on the mechanism. They have a lot of mechanisms of action, but one of their very exciting mechanisms of actions that have been proven and have been seen under microscopes is that they transfer their mitochondria to damaged cells. And so stem cells have mitochondria that have basically never been used. They've been in sort of this dormant state, these stem cells. And so the mitochondria are just sort of sitting there waiting to turn out the energy to do something, largely to help the cell differentiate, which is its first step. And so when they are infused or injected, and they are in the presence of damaged cells. There are signals that are sent to the stem cells, because everything is done by cellular signaling in our body. For the most part, I'm generalizing, of course, but cellular signaling is a lot of what our body does to sort of for communication amongst tissues and cells and organs. And so it receives these signals that it needs to repair these damaged cells. And one of the things that the stem cells will do is it actually develops this tunnel. I mean, it's incredible when you see it under video microscopy that are available to see. It actually forms this tunnel and transfers their mitochondria from the cell into the damaged cell, and basically, the way I describe it, infuses new life.
Right.
And it's extremely exciting to me. And I've, talked about this so often. And it's something that I really, really am an advocate for patients with mitochondrial dysfunction. And in the mitochondrial disease world, they are doing stem cell treatments. They are doing stem cell transplants and stem cell treatments. And I have a lot of, not anymore, but I used to have a lot of, pediatric patients who went to stem cell clinics to get this done because it wasn't allowed in this country, and would come back with a greater, with improvement in their symptoms. How sustained it is, obviously, at this point, I don't know how sustained it was for those children, but for adult patients who have received stem cell treatments, I continually talk to them, and they seem to have a sustained effect for a period of time. And then they have to go back and get some more stem cell treatment. So I do think that stem cells hold great promise for mitochondrial burden, because we can give patients basically new mitochondria and give their cells a chance to recover and regenerate.
So I think,
and maybe that's where the cocktail holds great value, by the way.
After you've gotten
right, after you've gotten new mitochondria, maybe the mitochondria are just so overburdened and so just sort of kaput that giving some supplements really doesn't do them any good.
So I think I talk about exosomes, and they are not stem cells, but they come from stem cells, and they are filled with all these signaling molecules. So while they don't have that mitochondrial transfer facility, they can't do that, their ability to build new protein and work on signaling and addressing all this inflammatory problems, et cetera, I think ends up in similarly fixing or improving mitochondrial function. I see it in patients who, they got their exosomes at a point where they come into my office in a wheelchair, and a week later they tell me they rode their bike.
Yeah.
Now, that has to be mitochondrial to some degree.
Absolutely.
So,
there's no question it's mitochondria.
Yeah.
And I do know that there's a lot of research in the ME/CFS world. I don't know about a lot. I don't know how I would quantify a lot. But I've seen several papers looking at the mitochondria, and they actually are finding evidence that the mitochondria are not functional. And so, just to talk about a workup again, there's the mito swab, which is a functional assay. And so it's just a buccal swab, and it looks at the functionality of complex 1, 2, 3, and 4 to sort of see where, but it's a point in time kind of testing, right? So it doesn't necessarily, you can extrapolate and decide, well, clearly they're not functioning well now.
And it's a point in time at rest.
At rest,
I think
correct.
That's an important thing.
Exactly. I know that Baylor has an electron transport chain analysis assay as well, which is also functional in nature, so not genetics. So there's a lot of different ways so I talked about the genetic part of the workup, but I should also say that I also look at, and I talked about the biomarkers on LabCorp and Quest, but there's also ways to check for the function of each enzyme complex. I didn't add, I just wanted to round out the workup that I do. So I also do the functional assays. So I get a lot of data to sort of realize like your mitochondria just are not working well. But sometimes clinically, you just, again, something that's so multisystemic, it just screams mitochondria.
Yeah, that's what I'm saying. Yeah.
Right, absolutely. And again, and their symptoms are so like, their brain isn't working, their muscles aren't working, they're chronically fatigued. And I can't explain why we don't find a lot of cardiac abnormalities. That's, I think, the one outlier, because the heart is so metabolically active, has thousands of mitochondria. You usually see things like conduction block or cardiomyopathies in true mitochondrial disease. We really don't see that a lot in our patients.
But that may be a function of their inactivity. That muscle's not being used.
That's true. The heart is not being challenged as much.
It's being used, obviously, but you're not.
So that's a good point. Yeah.
Should we talk about rapamycin?
Sure. Well, yeah.
Okay. So rapamycin, or sirolimus, is been around 50, 60 years.
A long time.
And it's used in transplant medicine to suppress the immune system completely. Right. So that the donor organ is not rejected. Like so many drugs, LDN being a great example, in very, very low doses, it has exactly the opposite efficacy or effects. It inhibits mTOR, which is a nutrient-sensing protein that is present in every single vertebrate on the globe and has been for millions of years. So if that's not a really important thing, it's been conserved evolutionary, from an evolutionary perspective. And by its role there, it activates another pathway, the AMPK pathway, which promotes, along the way, autophagy, which helps clean up these cells that didn't go through their appropriate apoptosis. And when we have these sick or just inactive cells, they're not actually inactive. They are producing cytokines and
that's the important point.
Chemicals which harm the cells around them.
It's exactly right.
So in some ways, it's a similar problem in obesity where the adipose cells are producing those active but not good cytokines. So the RAPA helps promote the autophagy and basically clean up. It's like activate the garbage system.
Right. And so when mitochondria are not working well, that's why we brought up how it controls apoptosis. Then it doesn't control apoptosis, and these cells are allowed to just sort of sit around in a very almost like corpse-like state, right? And they release these very inflammatory mediators. We talk about the mast cells all the time. I always think about all the cellular debris that's creating maybe more of a problem.
Well, causing mast cell activation.
Right, exactly. And causing autoantibodies to be produced, right? So, and they're releasing, yes, a lot more inflammatory mediators, all these cytokines. And so rapamycin helps come and clean all that up, which is why I think it's so effective and not used enough. And I don't really know why.
Well, the problems are we don't really know the right dose for this purpose.
Right. But we're not going to know the right dose if we don't study it and we don't use it.
I was about to say. And we don't know it because we're not studying it.
Right.
We don't have a kind of biomarker to decide who might benefit the most and when it's working best. So I use it in patients. I have patients on 5 and 6 milligrams once a week. I have other patients who get to 3, and when they go to 4, they don't feel good. They go back to 3 and they feel better.
Right.
So it is a titration process. We need
some
are all drugs
we
science,
use.
Right?
Yeah.
We need some trials, some research to look at how we monitor, how we measure, how we predict, how we come up with dosing. And we don't have those trials yet.
Right.
But like you, I can't wait for the trials. So
I know.
Our patients are too sick and I can't wait. So I'm trying, and I explain this is investigational, FDA
and I do
drug,
regular labs,
all that stuff, and we do labs. I have seen very little toxicity. Basically no toxicity.
Yeah.
And I think it's a drug that we need to really pursue. And as far as I'm concerned, I'm prescribing it way more now than ever before.
So am I, definitely. I mean, it's certainly obviously not our first line.
Right.
Probably not even our second line.
Right.
But, at some point you have to try to help patients because suffering needlessly, potentially, is not okay by us. So I'm always willing to try something. I always start very low. I go very slow. I do lots of labs. I check in with them often. But I really like rapamycin, and I think it holds great potential. And by the way, it's not like we've used it for other diseases. I mean, I've used it a ton of times for tuberous sclerosis. It's major in pediatric neurology. It's what we use for those kinds of abnormal growth disorders that affect the brain. And so we know a lot about it. And just mTOR inhibition in general, when you learn about what it does and how it just sort of helps clean out not only cells that are not being cleaned out by other mechanisms, but also it reduces the ability for atypical and damaged cells to replicate if they have any of that potential capability left over. It inhibits their ability to do so. So it just really, I think it protects the organ systems in ways that are really important for our patients, for sure. And it's been one of my most recent, more favorite drugs to start.
Mine too.
Yeah. So I really like that idea.
So one of the other things about mitochondria and intervening is exercise.
Yeah.
And I realize this is a delicate topic for our patients.
It's a very delicate topic.
But I think it's worth talking about for a second. So moderate exercise, so-called zone 2 exercise, which is all zone 2 basically means you're not getting into an anaerobic stage of your exercise. So, it usually there's a heart rate determinant, but an easy way to know is if you can talk and exercise at the same time, that's zone 2. Okay, that has been shown to increase mitochondrial health and biomass, meaning it grows new mitochondria. So one of the challenging questions, which I'd love to figure out a way to address, is how can we take our fatigued patients, not the bedbound, I think that's too challenging at the moment, and get them onto a zone 2 program where they don't develop PEM? Is there a way to do it artificially even? And I don't know the answer to that, but the data on the effect on mitochondria is so profound that it should be looked at more carefully because it's not a drug. I mean, it's
right.
So
I often wonder if just because they're in such sort of a state of fatigue, if even just things like gentle stretching or physical therapy can bring them to zone 2. And, I haven't yet suggested it to patients because I'm afraid that it's going to crash them. And I don't want to be responsible for that. But I often have that question. I wonder what their heart rate would be just doing those kinds of very gentle, passive exercises.
Right. And don't forget, zone 2 is different for each person.
Yes.
So my zone 2 may be a heart rate of 125 or 120. And if I follow the age thing, it's even lower. But an ME/CFS zone 2 maybe keep your heart rate at 90. But that's doable.
It is doable.
And I've started asking patients to consider going for a walk with their heart rate monitor and just monitor their heart rate. And if they're at 90 after half a mile or a quarter of a mile, then they can stop. Those little efforts help. But it's a delicate balance because patients start to think, oh, you're just telling me to work out or get into shape, that's why I'm this way. And that's not what I'm saying.
No.
It's absolutely not the situation. This is actually a treatment. It's a dose. Think of exercise as another medication to titrate the dosing.
That's a good way of actually couching it, because it's true. Even when we give a medication, there could be a mast cell reaction.
Right.
And we say, try a low dose. If you have an adverse effect, we'll stop it.
Right.
So I guess exercise can be considered in the same realm. So I like that, actually. Yeah. So I'm going to start recommending that just as you described it, because I think it's important. And I do think it's important that patients sort of just see what their bodies can tolerate. And, I often say, you'll know when it's too much. And maybe you won't, but you'll know that maybe the next day that it was too much. And so you'll have to back off, what you did.
Right. That's exactly
right. And because everyone's body is different. And so it's hard to actually give a prescription, I think. But it's really just sort of just tell me what it felt like. And then we can sort of decide together what your next dose of this kind of exercise will be.
Exactly.
Yeah. I think it's important because exercise has been shown over and over again that it does increase the number of mitochondria and mitochondria mass for sure. And mitochondrial function. So the integrity of its bioenergetics, which is important because it's what the mitochondria do.
Right. Right.
So yeah, I agree. So exercise, nutrition, of course, plays a huge role.
Right.
And there's often this talk about, the ketogenic diet versus, dextrose actually has been very effective at mitochondrial support. But some patients feel that the ketogenic diet has been helpful. But there's a lot of concomitant fatty acid disorders that are masked by mitochondrial dysfunction. And so, which is why I think that some patients don't feel good on a ketogenic diet and some patients feel great on a ketogenic diet, by report, of course. And so I think that's an area that needs to be studied more, but we know nutrition plays a huge role. So we all need good nutrition. I think everyone can agree that, avoiding processed foods and processed sugar and, donuts and cookies and all that
low
good
carbs.
stuff. Low carbs, right. Simple carbs should be avoided. So yeah, I think there are simple things that we can do to support our mitochondria, but our patients, are chronically ill and have been sick for a really long time I think even exercise will only go so far. I think even nutrition will only go so far.
Yeah, there's not going to be a single panacea here, a silver bullet.
Isn't.
That's clear.
Yeah, and I agree with what you said about the cocktail supplements. I will say that IV seems to have a greater effect, and that's
not a surprise.
Right. And so, but obviously not easy, to do, more expensive. They have to travel someplace for it.
Right.
We do a lot of IV support in our clinic. And there's definitely a response, or at least, some response, as opposed to when they're taking oral supplements, there isn't that much of a response. Right. So I do think that there are, and we go back to this. I think it's tailored. I think it's a little bit personalized. I take patient by patient and I listen to the symptoms and I decide, the workup, what we're going to do, how we're going to treat, and where we're going to go from here. And I think that's where mitochondrial dysfunction in chronic and complex illness sort of stands right now.
Right. I would add, and I know you do this, that you can't address the mitochondria on the first visit. You need to deal with the low-hanging fruit, as I said before. Is there an infection and can it be treated? Is there POTS and can it be managed? Is there active mast cell and can it be managed? Because those are the things that are knocking our patients down. The issue with mitochondria is once we actually manage those, why are they still so tired and post-exertional malaise all the time?
Right.
That's the mitochondria.
That absolutely is, for sure. So yes, treat the mitochondria.
And I think we should still do a separate podcast for exosome stem cells.
We will.
Rapamycin, one of these days.
You see our Patreon page. There was a couple of comments that say, every episode you say that and you still haven't done it. We will. There's just a lot to say.
Right.
And we want to make sure that we...
Right. And we didn't even touch on peptides and mitochondria.
No. Well, I was going to say that peptides play a huge... So MOTS-C is my favorite peptide for mitochondria.
SS31, that's another one.
I love SS31. And then Amlexinox actually has become another one.
These are like
my
teasers
favorites.
to our
Teasers.
subscribers.
Well, if any of our patients are listening, I mean, this is what we do. So they know what we're talking about. Because usually when I'm recommending one of these, I go on a whole spiel about why I love it and why I'm recommending it and why you should take it. So, but all right. So this was a good conversation.
Yeah,
I'm glad we had it.
Very
But we
good.
will eventually do a dedicated one.
Critically
to all these
important
things.
conversation.
Yeah, very important. So, okay. Thank you for joining us. This has been Unraveled with Doctors Ruhoy and Kaufman. And we will see you next time. Bye.
Bye.